Our next drug on our list is sodium valproate, also known as valproic acid or sodium valproate. It is an organic weak acid and is a medication primarily used for epilepsy. It is a broad spectrum anticonvulsant, although it is primarily used as first-line therapy for tonic-clonic seizures, absence seizures, and myoclonic seizures, and as a second-line treatment for partial seizures and infantile spasm. It has also been successfully given intravenously to treat status epilepticus. Its anticonvulsant effect has been attributed to the blockage of voltage-gated sodium channels and increased brain levels of gamma aminobutyric acid. It is unclear how exactly valproate works, but the proposed mechanism include affecting GABA levels and blockage of voltage-gated sodium channels. The most common side effects include nausea in 22% of cases, drowsiness, dizziness, vomiting, and weakness. Serious side effects include low platelet count, bleeding, encephalopathy, and hypothermia. Exposure during pregnancy is associated with abnormality like spina bifida, more rarely with several other defects including a valproate syndrome. Its contraindications include pre-existing acute or chronic liver diseases, pancreatitis, and porphyria of epileptic patient. Status epilepticus is a single seizure lasting more than 5 minutes or 2 or more seizures within a 5-minute period without the person returning to normal in between these seizures. It is a life-threatening medical emergency, particularly if treatment is delayed. The seizure is usually of tonic-clonic type.
Everything you know is in your mind.
The treatment protocol includes benzodiazepines as a preferred initial treatment, after which typically phenytoin is given. The possible benzodiazepines include intravenous lorazepam as well as intramuscular midazolam. A number of other medications may be used. If these are not effective, then valproic acid, phenobarbital, propofol or ketamine. Intubation may be required to help the person's airway maintained. Between 10 to 30% of the people who have status epilepticus die within 30 days. Benzodiazepines, as we said, are the preferred initial treatment, after which typically phenytoin or fosphenytoin is given. When given intravenously, lorazepam is superior to diazepam for stopping the seizure activity. Intramuscularly, when given intravenously, lorazepam appears. Intramuscular midazolam is a good option, especially in those who are not in hospital. Phenytoin was once another first-line therapy, although fosphenytoin can be administered 3 times as fast as and with very few injection site reactions. Before the benzodiazepines were invented, barbiturates were preferred, which are still used. If benzodiazepines or hydantoins are not an option, the barbiturate most commonly used for this is phenobarbital. Valproate is given intravenously and can be used for status epilepticus. If all these measures proves ineffective, then general anesthetic propofol may be tried. Sometimes it is used second after the failure of lorazepam. Propofol has been shown to be effective in suppressing the jerks seen in myoclonus status epilepticus. Ketamine can be used as a very last resort for drug-resistant status epilepticus. And last but not the least, lidocaine has been used in cases that do not improve with other more typical medications.